Assalamualaikum and good morning, everyone. Okay, so my name is Nolaila Mustafa. I'm from Department of Medicine. So I'm very pleased to chair today's CPC, in which Department of Medicine gonna present, and we have four presenters today. Dr. Lim Kuan Yee is a registrar from the Department of Medicine. Dr. Fong Woon Ken from Nephrology Unit Department of Medicine. We also have Prof. Madya, Dr. Nur Dashima Abdul Shukur from Department of Pathology, and Prof. Madya, Dr. Norashikin A.Wahab from Endocrinology Unit Department of Medicine. So you can see that the theme or the title for the CPC today is Eat That Frog. So I think I must convey this to all the presenters. You guys eat that frog. Okay, we'll start with Dr. Lim Kuan Yee.
Thank you, Prof. Laila. So let me share my slide. So a very good morning to everyone. So I will start with the case presentation. So I have a 71-year-old Malay lady who is referred to nephrology clinic for evaluation of proteinuria. She has a background history of hypertension for 15 years, diabetes mellitus for 3 years, and chronic kidney disease with a baseline creatinine of 150 micromole per liter in December 2019. Otherwise, she has no other macrovascular or microvascular complications of diabetes mellitus. Her main concern was about her proteinuria, and she denied any other symptoms such as leg swelling, nausea, vomiting, breathlessness, urinary symptoms, symptoms to suggest connective tissue disease, and constitutional symptoms.
Dr. Lee,
yes.
Before we go on, how long was the the hypertension was 15 years already. Do you know what was the medication she was on for the past 15 years, and how was the control like? And similarly for diabetes, although it's just for 3 years. The audience would like to know that.
Yeah, the hypertension medication I actually will list out later on, but basically she's on 3 antihypertensive medication, perindopril, atenolol, and amlodipine. And the BP control is slightly uncontrolled with a systolic pressure of 150 to 160, which I will show in this one. But regarding the glycemic control wise, I just get to know that she is on gliclazide, but I'm not given information regarding her glycemic control actually.
And maybe someone can answer that. Because it is nice to know about the control of the disease that the patient's having, right?
The diabetes was diagnosed 2 years ago, and she was on only single agent. The HbA1c with us, right, is actually a few readings, but always around like 6.5 to 7. Yeah, around 6 each.
Right. And how was she diagnosed diabetes mellitus? Is it because she has symptoms? You can see that she's 71 years old. Diabetes, meaning that she was diagnosed at the age of 68. Usually in Malaysia, when you talk about diabetes, most of the patient were diagnosed much early on. They may be symptomatic, or they diagnosed because of screening being done, things like that.
They pick up the diabetes during the screening. As usual, they screen the urine and the blood test, then they pick up diabetes.
All right. Okay, carry on, Dr. Lim.
So her clinical examination reviewed no evidence of fluid overload, and her blood pressure was 150 to 160 over 80 millimeter mercury, and she has a normal heart rate. These are the information that I was given regarding her clinical examination. So her initial investigation.
Right, Dr. Lim. Sorry, being a clinician, right?
Yes.
I think the clinical examination. I'm sure you know a lot of us here, the audience would like to know a lot more with regards to the clinical examination or physical examination. I'm sure being a nephrologist or endocrinologist, we want to know whether what's the weight of this patient like. Okay, is she obese? Is she thin? And any other evidence of complication from diabetes or from hypertension. Do we have that information, please?
Yeah, sorry, maybe you can ask Dr. Ken because I was not given the information.
So from a clinical examination, it doesn't reveal any sign of heart failure. The apex beat is not displayed. There's no raised jugular venous pressure, and then apart from that, the blood investigation the investigation that they have done is the ECG. The ECG does not having any left ventricular hypertrophy, but we didn't perform any echo on this patient.
Right. What about the retinopathy screening? She's diabetic. She's also hypertensive. Any fundoscopy done?
Yeah, we have referred to ophthalmologists as well. I think it was presented just now on the first slide. She doesn't have any evidence of macro or microvascular complication. It was sent for the ophthalmologist. There's no retinopathy, just pseudo, pseudo phakia, something like that. Yeah.
Right, interesting. All right, carry on, Dr. Lim.
Okay, so her initial investigation revealed that there is a rapid deterioration of kidney function over 2 years' time, basically from 2019 to 2021, with creatinine rising from 150 to 270 micromole per liter, and the eGFR declined from 30 to 15 milliliter per minute per 1.73 meters square over 2 years duration. She has a normal serial albumin of 35 gram per liter, and her urine FAME shows 3 plus protein and 1 plus blood. And urine PCI was sent, it was 1.33 milligram per millimole, which is equivalent to 13 gram of proteinuria per day. She was also noted to have anemia with a hemoglobin of 8.6 gram per deciliter.
Right. Okay. If I can stop you now, what are your differential diagnoses this point of time, Dr. Lim?
With background history of diabetes and with the presence of proteinuria and also CKD, differential diagnosis will be diabetic kidney disease. The CKD and proteinuria can be also due to hypertensive nephropathy, and the rapid deterioration of kidney function over 2 years, it can be due to diabetic kidney disease with heavy proteinuria causing the deterioration. For her,
apart from diabetes, hypertension, anything else that you want to think about?
In her with heavy proteinuria but a normal albumin, it can be due to even with primary glomerulonephritis such as membranous GN or even in maybe IgA nephropathy with FSGS when the urine FAB shows 1 plus blood and then there is heavy proteinuria. Also, it can be due to overflow proteinuria, such as in the presence of paraprotein, like myeloma kidney or even amyloidosis.
All right. Any other differential apart from what you mentioned?
The differential, it can. Maybe there's the use of traditional medication or even NSAIDs to cause the deterioration of kidney function.
Okay, right. Okay, never mind. Carry on, Dr. Lim.
So ultrasound was done, which showed that she has an atrophic left kidney with a size of 5.9 centimeter and a normal size right kidney of 10.9 centimeter. And the renal biopsy was done for her.
Why was renal biopsy done, Dr. Lim? What do you think? Your differential diagnosis seems to be, weird towards diabetic kidney disease. Do you do a renal biopsy in somebody who you suspect to have diabetic kidney disease?
So I think if you suspect a diabetic kidney disease and already a shrunken kidney, so usually we don't do renal biopsy. But I think the renal biopsy was done maybe because this patient has diabetes noted is short duration of 3 years, and there is no presence of other microvascular or macrovascular complication. So particularly there is no retinopathy. So that's why I think that the decision of renal biopsy was made. Maybe to look for other primary glomerulonephritis, as a primary renal disease. Can
I just ask you, Dr. Lim, if let's say it's due to diabetic kidney disease and on ultrasound you found a shrunken kidney already, do you think, are you happy with the diagnosis of diabetes for the past 3 years?
If a very short duration of diabetes, then maybe there is other reason behind why there is a rapid deterioration of renal function. So maybe the only way to know whether it is due to diabetic kidney disease or not is by a renal biopsy. But if the kidney already shrunken, then I don't see any reversibility of the condition that can be solved.
I understand that, but you as a physician, you want to know what's causing this woman to have a small kidney bilateral, unilaterally, and at the same time has proteinuria, right? You also has mentioned a few differential diagnoses. Then from your differential diagnosis, since she doesn't have any other symptoms, how are you going to come to a most probable diagnosis, whether it's diabetic disease, whether it's your paraproteinemia, or whether is it because of vascular problem and things like that? Which one would be the most likely? Put all your investigations together that you have in front of you now.
So I think before we do somehow like invasive procedure like renal biopsy, basically we can screen for whether presence of evidence for things like multiple myeloma by checking the total protein, Ag ratio, serum calcium, or even serum and urine electrophoresis.
Before you go and do all the other extensive blood investigation, what other simple investigation you want to do first? If you want to go back to your slide before this, your previous slide, okay? This is also for the sake of medical students, which I hope they are here. This may be a simple case to you, but the approach has to be, very clinically orientated and something that is simple and makes sense, right? Okay, so looking at your investigation, I know you've showed the clinical examination, which I would want a lot more information here, not just no evidence of fluid overload or blood pressure and normal heart rate. A lot more I would want to know in 71-year-old woman who came in with proteinuria and a long-standing history of hypertension and also diabetes and with impact renal function. Okay, I can tell you here, you don't have the weight, you don't have the heart rate, you don't have the evidence of a complication that, you know, most of us would like to know, including a proper eye examination before I ask you. Then if you go to your next slide, investigation, if you go to your next slide, okay, so you from here you have this information, but you also have your differential diagnosis. Remember, I asked you for your differential diagnosis.
Yes, yes.
Okay, so what else you want to, based on this investigation that you have in front of you, what are the simple investigation that you want to send?
Simple investigation.
Yes, or you go on and send for, you know, all the paraprotein and so on. Discussion.
Urine. Sorry.
You already have protein 3 pluses there and PCI, and you don't need urine albumin, right? Because you know there's a lot of protein in the urine. Anything?
Bedside random blood sugar to see what is the glycemic control. And
you already told, Dr. Ken already told us that the HP is about 6 point something, is basically within target. And she's on medication. So I think I'm pretty happy with that for now. Any other investigation?
Other investigation. I see, to check for
because you have your differential diagnosis, okay, that you mentioned.
A full blood count, peripheral blood film to look for the cause of anemia.
Okay, you have your hemoglobin there, 8.6 grams.
8.6, yeah.
Yeah, not full blood count. What more than full blood count? What else you want?
As in peripheral blood film, iron studies and ferritin level, vitamin B12 and folate level.
Okay, before you
to determine the cause.
Dr. Lim, okay, you have hemoglobin 8.6. You said you want to send for full blood count. What you want to look for in full blood count?
Looking for basically the type of anemia to see whether it's the normal chronic lymphocytic anemia.
Okay, right. Apart from type of anemia, what else you want to know from the?
So also to look for pleural formation to suggest to suggest.
Would you be able to? Would you be able to see that from your full blood count?
I mentioned peripheral blood film.
Full blood picture, right?
Yeah. Peripheral blood film, yeah. Full blood.
Yes. So you know, I would rather you go for, you know, this initial investigation first, rather than, you know, straight away go for renal biopsy. Is that right? That should be the approach, right?
Correct.
Yeah. So you should have excluded all the other things first, okay, before go on and ask for any invasive procedure for this 71-year-old lady or woman, right?
Yes. So yes, Prof, I agree, because I'm not sure why the renal biopsy was done immediately. Without further investigating the other possible cause with non-invasive methods.
Yeah, but I'm asking you because you have your differential diagnosis. The moment you have your differential diagnosis, you should be asking for other investigation to support or exclude your differential diagnosis before you go on and do any other invasive procedure. Okay, and this is for also to teach the other junior doctors and the medical students. All right. Okay. All right. Go on.
So her medications. This is a list of medications she's on: gliclazide, peridopril, atenolol, and amlodipine.
Right. Dr. Lim. She
yes.
is her GFR is 15 mils per minute, and she's on gliclazide 14 milligram daily. Is that all right? Are you happy?
With her low eGFR, I think she will have high risk of developing hypoglycemic episode with the sulfonylurea group of antidiabetic medication. So maybe we should how to monitor her glycemic control and maybe change to something else that can with no risk of hypoglycemia, which is like DPP4 inhibitors.
What type of how many types of sulfonylureas that you know of?
Gliclazide, sulfonylurea. So gliclazide, glibenclamide.
Gliclazide is what generation, Dr. Lim?
2, second generation.
You sure? What about glibenclamide?
Glibenclamide, 1, first generation.
Okay, what about chlorpheniramine?
Sorry, Prof, I'm not sure about that.
Okay, right. So how was gliclazide being metabolized? Where?
Metabolized and excreted by kidney. I'm not sure, but I think it's excreted by kidney. That's why with the reduced eGFR, it might cause the risk of hypoglycemia.
Metabolized?
Metabolized.
Okay, it's important to know where the drugs is being metabolized, excreted as well in somebody who had impaired kidney function. That will then guide you whether is it okay to be used in somebody with GFR of 15 mils per minute or not. Okay, it is metabolized in the liver, excreted by the kidney. So if you ask me, is it okay? People sometimes reduce the dose of gliclazide. It's still okay to be used. All right, so continue, Dr. Lim.
So this was the summary of the case. Basically, a 71-year-old Malay lady, long-standing hypertension, 3 years duration of diabetes, and CKD presented with faulty urine with nephrotic range proteinuria, but a normal serial albumin and rapid deterioration of renal function. Clinical examination revealed uncontrolled hypertension, otherwise unremarkable. Ultrasound revealed an atrophic left kidney and a renal biopsy was done for her. So this was what I mentioned earlier. My provisional diagnosis is diabetic kidney disease based on the background history of diabetes, nephrotic range proteinuria with normal serial albumin, and there is a deterioration of renal function. However, there is no evidence of diabetic retinopathy, and somehow the shrinking of the kidney is unilaterally atrophic. So the differential diagnosis, like,
do you know whether is there any renal bruit on physical examination?
I was not given this one information, but I think it was mentioned that there is no evidence.
Yeah, is it important knowing that she has unilateral atrophic kidney?
Yes, because of the possible of renal artery stenosis. So like I mentioned just now, the differential diagnosis in the condition with heavy proteinuria with a normal serum albumin, it can be glomerulosclerosis due to, besides diabetic nephropathy, it can be hypertensive nephropathy in focal segmental glomerulosclerosis due to underlying primary GN such as IgA nephropathy, FAGS, membranous GN, or even overflow proteinuria, like I mentioned just now, maybe myeloma kidney amyloidosis. The differential diagnosis for unilateral atrophic kidney, I was thinking maybe there is presence of unilateral renal artery stenosis. It can be something pre-existing, like congenital hypoplasia or pyelonephritic linkage previously. And also it can presence in, let's say there is asymmetrical glomerulosclerosis, means one kidney become atrophic first. So this one, so in view of all the differentials and the provision diagnosis, so of course to further investigate, I would like to check on her glycemic control. This one, which Dr. Ken already mentioned, that the HbA1c was around 6.5% most of the time. Sorry.
Yeah, I think we've asked about all the investigation. I think to me, you should be asking for further investigation before you come to a differential diagnosis. Because it will then guide you where you are heading later on before you go on and ask for renal biopsy. Right. So, but by the way, because all these things are not actually mentioned, maybe we can ask Dr. Ken later. What do you expect in renal biopsy? What you want for?
If I'm expecting the case to be a diabetic kidney disease with already atrophic kidney, so I think we will see in renal biopsy at least a grade 3 or 4 of diabetic nephropathy. Basically, the presence of maybe a nodular mesangial expansion with sclerosis, or even the evidence of advanced diabetic glomerulosclerosis in the renal biopsy.
Right, if let's say you think that your other differential, for example, is myeloma or amyloidosis, what would you expect in the result of renal biopsy? What will you be looking for, or what will you be asking the pathologist to see?
So it might appear to be same as with messenger expansion, but we will need a Congo-Rex stain to look for to confirm whether there is amyloidosis, presence of basically paraprotein.
Paraprotein in the renal biopsy?
Basically amyloidosis, deposition of amyloid by Congo-Rex stain.
Right. What about if it's FSGS?
FSGS, then we can see the evidence of segmental glomerulosclerosis. Basically, we can see at least more than 50% of glomerulus are having segmental sclerosis, means more than 50% of the chrome is has sclerosis.
Right. Okay. Carry on, Dr. Lim.
So other investigation, actually before the renal biopsy, we should do maybe an ultrasound Doppler of kidney to confirm whether there is evidence of renal artery stenosis. And of course, like I mentioned just now, other investigation includes the workup to look for evidence of multiple myeloma and also anemic workup. Yeah.
Yes. Do you have any more slides, Dr. Lim?
That's all I have for this one, for the case.
Okay, Dr. Ken, can I ask for most of the results that Dr. Lim requested? Do we have? You can just mention it out.
Yeah. We do not have the Doppler ultrasound. The total protein, the AG ratio is not reversed. For the swab, serum and urine electrophoresis, it just mentions a tubular protein. It's an overflow protein. Calcium level is normal. Peripheral firm, there's no urinary formation. Iron studies and ferritin are remarkable. And a B12 on folate level also unremarkable. And the full blood picture suggests the anemia of a chronic disease.
Okay, and renal biopsy was done.
Yeah.
Okay, right. Can we then ask Dr. Prof. Dashima to share her slides with us?
Okay, I shall be sharing my slides. Hold on. Okay, Assalamualaikum. I shall be discussing on the renal biopsy finding. Okay, what we receive is a core of renal cortical tissue. This is a core of renal cortical tissue, and there are 15 glomeruli in the place of section. What you see, the rounded structure here, I hope you can see my cursor. The rounded structure here are the glomerulus. In between are the renal tubules, the proximal and distal convoluted tubules. And the smaller picture show two glomeruli which are globally sclerosed and one functioning glomeruli. Okay. On a higher power, what you see here, this is what we call as globally sclerosed. That means the whole glomerulus becomes sclerotic or scarring, and it's not functioning at all. There are 10 out of 15 globally sclerosed glomeruli. And to highlight the sclerotic changes, we further stain using silver stain, Jones silver stain, that will show the sclerotic area become black. And the insert show the whole glomerule globally sclerosed. And there is one glom which show just segmental involvement. And another glomerulus, this is a picture of one glom, where we use a few stain to highlight the changes. For the first picture on the left, you can see there is this nodular formation. Nodular formation here, just by H&E, difficult to say whether this is amyloid deposition or not. Is it due to other reasons? So we do further stain using PAS and Jones silver stain to confirm what is the type of this deposition. If we see again on the H&E, the center is acellular and the messenger cell being pushed to the sides. And it is being highlighted here in the PAS stain, and in Jones silver stain, the specific area become black. So it do show this is a sclerotic region. This is what we call as Wilson nodule, and it is quite small. So my interpretation for this glom, there is a presence of early formation of Wilson nodule. And this nodular sclerotic lesion, which is sclerotic like this, can be seen in a diabetic nephropathy, but there are several other differential diagnoses actually, but we have to correlate with the overall picture of the patient. Apart from that, the remaining glomerulus show expanded mesenterium. The white area is the capillary lumen, and the messenger supporting cells are increased in number. So there is mild messenger hypercellularity. This another glomerulus also show the similar expanded area with increased number of the messenger cells. However, there is no subepithelial, subendothelial, or crescent formation seen. And you see in this picture, the basement membrane is not really thick, but there will be some area appear a bit thickened. We also do another stain what we call a mesenteric stain. This is to highlight the fibrotic region. So apart from the glomerulus, we studied the interstitial area whereby the tubules, the rounded structure of the tubules should be back to back, but here become atrophied. And in between these atrophied tubules, the stroma is a bit fibrotic, highlighted by the mesenteric stain, become blue. So there is a moderate tubular atrophy and interstitial fibrosis. And there is no any cast seen in the lumen to say whether it's myeloma cast as one of the division just now, or the inflammatory cells within the incision are just scanty lymphocyte. We also assess the vessels. Okay, for the arterioles, it is mild to moderate thickened, and there is mild hyalinosis. Hyalinosis can be seen in diabetes, can be seen also in hypertension. And you can see the surrounding stroma show presence of some lymphocytes. Okay, apart from doing the HNE assessment for the special stain to highlight the changes, we proceed with immunofluorescence study. This is study to categorize the disease process. The use of immunostudy, it can detect the immunoglobulin deposition, whether it's IgA, IgG, IgM, or any complements. Okay, the background picture that I show here actually is a case of membranous nephropathy where you can find nice granular deposition highlighted by this immunofluorescence study. However, for our patient here, we're able to assess 4 glomeruli. There's only 1 plus intensity to 2 plus intensity of C3 and IgM, which is very focal. The reason to this is could be a non-specific entrapment due to the cementous scars or incidutive lesion. The C4 and IgA were negative. But for the IgG, the IF studies show this nice finding of linear positivity along the capillary loop. And this also can be seen in a diabetes case. So what we see overall, for the renal biopsy, there is a diffuse sclerosing pattern whereby there's either global or segmental glomerulosclerosis, which amount to 66% of the glomerulus. And there is also one glomerulus that show an early nodular sclerosing pattern. And the background, there is mild to moderate hypertensive vascular changes and moderate chronic tubular interstitial damage. So based on the morphology and IF study, this overall picture may represent a diabetic nephropathy with the background changes of hypertensive vascular changes. Okay, that is for the biopsy. Thank you.
Right, thank you, Prof. Dashima. Meaning from the renal biopsy, there's actually 2 pathology that contributes to the deterioration in renal function, if I can say so. Okay, right. What about the nodular is not that extensive, right? The nodular changes, the KW nodule that we expect in diabetic nephropathy.
Yeah, this one you just can see the nice one in 1 glomerulus of the 15. But bear in mind, majority having the glomerulosclerosis, 10 out of 15.
That can be due to the long-standing hypertension.
Yeah.
And also in diabetes.
Can be both.
Yes.
That we can comment.
Yep. All right. Thank you. Okay. Dr. Ken, you want to say anything before we actually go on and ask Prof. Shikin to present? Or Dr. Lim, any comment?
Thank you, Prof. Dashima, for very nice slides presentation. So I think this lady have a history of 3 years of diabetes mellitus with a relatively well control of the HbA1c when she came to us. But we do not know when was the diagnosis diagnosed in the past. Probably she had an early onset, we didn't know. And then the unilateral atrophic kidney, it might actually showing that patient might have a renal atherosclerosis in the past, causing a atrophic kidney on the left side. So put everything into a picture, right? She might have a atrophic kidney, causing all of the kidney damage and leads to the glomerular sclerosis. And on top of that, right, the poor control DM is actually comes to the picture. So in the end, having all of this proteinuria. Yeah.
Okay, Dr. Lim, you happy with your diagnosis, your differential and the final diagnosis confirmed by the pathologist?
Yeah. Yes. It's how to say. Is correct. Is confirmed with the my provisional diagnosis confirmed with the renal biopsy. But of course, it's a bad news for the patient as the thing is already irreversible and is progressing. So of course she might need a replacement therapy in the future.
Okay, before I ask Prof. Shikin to present, as a registrar, why do you think, despite the good control of diabetes that she has now on low dose of sulfonylurea, why the deterioration in kidney function is very fast?
Because of basically she has very heavy proteinuria, so that one is one of the markers to predict the progression of CKD in diabetic.
Yes, that showed that the progression of the disease. My question is why the disease or diabetic nephropathy is progressed pretty rapidly in 2 years, despite having a good diabetes control A1C of 6 point something. Maybe falls below because HB is low, but the nephrologist seems to be very happy with the sugar control, but why the kidney deteriorate very fast?
So I believe that her diabetes mellitus might be undiagnosed previously. It's maybe not only 3 years duration. It's just that by screening incidental findings of diabetes, so she might already have the diabetes for quite some time. They only diagnosed 3 years ago. That might be the reason. And of course, when she was diagnosed with diabetes, her eGFR was 30, so that can somehow.
We know, Dr. Lim, you did not answer my question. Why within 2 years the GFR fall down pretty rapid in this woman from 30 to 15 mils per minute?
So
seeing a nephrologist here. Why do you think? What is the reason?
The reason, really heavy proteinuria and uncontrolled hypertension can be contributing.
Uncontrolled hypertension. What's her BP like?
Still
presentation.
150 to 160 systolic.
What is the BP that you should be aiming for in this woman?
So based on the latest diabetes CPG guideline, the target BP in diabetic kidney disease with proteinuria should be systolic of 120 to 129 over 70 to 79.
Right. Thank you, Dr. Lim. I can now ask Prof. Shikin to present. I hope we can end the CPC by 9.
Okay. I would like to share. Okay. Assalamualaikum and good morning. Thank you, Madam Chairman, and then as medical department and others actually. And proceed, which is a basic in terms of about diabetes, just for a few slides only. So everybody know that diabetes actually increase all over the world actually, and in the what we call roughly in 2017, based on the IDF data, roughly 425 million, and we increase up to nearly 650 million in 2045 basically, and 30% to 80% actually people with having diabetes actually they are undiagnosed to have a diabetes, and other than that actually 80% of the diabetes actually burden for the low as middle economic countries. How's roughly 1 in adult globally have a diabetes. How about the Malaysian actually? Based on the Malaysian data on 2019, based on the what we call survey, it shows roughly 18.3% having diabetes, and in Malaysia actually roughly 1 in 5 of our adult population they have a diabetes. So based on the study, it shows that the highest population having diabetes, because this is a survey, roughly 31.4%, followed by Malay as well as the Chinese. And bear in mind, roughly nearly 20% of our population, they have HbA1c more than 10%, which is a poorly controlled diabetes. So for the benefit of, especially for the medical student here, actually you can see that my slide in terms of the natural history of the diabetes, you can see here that before you get the diabetes, you will get started with a pre-diabetes. The pre-diabetes actually is in IFG, impaired fasting, or it could be impaired glucose tolerance. So, and then we call it pre-diabetes, and then we progress to actually a diagnosis of diabetes. The diagnosis of the diabetes, it could be for many years, up to even 10 years actually. And once you started having diabetes, you can see here that the beta cells started deteriorated. Based on the study, it shows that roughly nearly 50% of the beta cell might be lost already when being diagnosed to have a diabetes. Once you lost a beta cell function, definitely the insulin level, because being produced by beta cell, will drop. Then you will see that the glucose actually started climbing up. In the type 2 diabetes here, actually you are looking at the insulin resistance, and you can see here, which is the complication, which is macrovascular complication. It started earlier, actually, even before you've been diagnosed to have full-blown of diabetes. So here, actually, the diabetes actually affect the head. For this patient, actually, she being what we call having a diabetic nephropathy for the head, definitely. For the medical student, roughly, they might having stroke actually higher, which is 2 to 4 times. And they also, we have it 4 of 10 actually individual diabetes actually died because of CV event. They also having diabetic retinopathy. So diabetic retinopathy as a nephropathy, this is, we call it microvascular. They also, we have atherosclerosis as well as neuropathy. So here actually is majority of the cases in type 2 diabetes, actually the presence of albuminuria with a coexisting retinopathy. But bear in mind, roughly 3% of a type 2 diabetes, they develop albuminuria at the time of the diagnosis. It could be because of undiagnosed diabetes or because of pre-diabetes, they already started having complication, which is I showed earlier in the previous slide. And 1/3 of a diabetes patient who have a diabetic nephropathy, they might don't have a retinopathy. So it could be that's how to explain, even though it's a very short duration for this patient, which is might be undiagnosed. That's the reason when the patient coming already with a complication. So what actually we learned actually from the previous trial actually for the diabetes actually in terms of the complications. So based on the landmark trial for the diabetes, which is a DCCT, diabetic control clinical trial, as well as this is for the type 1 diabetes, UK-PDS, United Kingdom Progression Diabetes Study, which is in type 2 diabetes, both actually shows that the intervention group shows that there is a markedly reduced in terms of the microvascular as well as a macrovascular complication. In fact, in the UK-PDS study, it shows that the patient with a lower fasting blood sugar at the time of the diagnosis, they have a fewer vascular complication. Here actually is looking at the what we call legacy effect, which is when in this both study actually is they will divide into intervention as well as the standard regime treatment. When they will what we call intensive growth, they will drop in terms of the HbA1c faster, but after follow up, even after completed the trial, when the HbA1c despite of almost similar rate, let's say for 7%, the complications still high in the standard regime basically. So we learn actually from this one actually the benefit of early diabetic control on subsequent development of a diabetes complication. So when you're talking about the legacy effect, actually you would like to know how soon actually legacy effect begin, on what control of a glycemic actually you required actually. So based on the very huge cohort of a diabetes and aging study looking at the legacy effect in newly diagnosed diabetes, actually roughly more than 30,000 in US, actually they are looking and follow up in terms of the cohort of this patient. When the patient who has a HbA1c of more than 6.5% for the first year after diagnosis is associated with increased risk of micro as a macrovascular complication, and those having HbA1c 7 and above is associated with increased risk of the mortality. And in this study also shows that the longer exposure of HbA1c more than 8% actually is associated with increased risk of the microvascular event as well as a mortality. So based on this clinical trial, based on the research actually, it shows it to us that's what we need to do actually. The most important actually because of the legacy effect actually to lower down our patient's HbA1c faster as soon as possible, regardless in terms of what the treatment you would like to start to your patient. But definitely it depends on what's the HbA1c of your patient. So for my last slide, actually, just would like to show it actually for the benefit of, especially for the medical student. This is where from I'm taking from the CPG, from the Malaysian CPG, the latest CPG, the treatment for the type 2 diabetes. You can see here that we divide based on HbA1c, and then the higher your HbA1c, maybe you would like even to start your patient with insulin rather than play around with oral hypoglycemic agent. Actually, even though when you are using the oral hypoglycemic agent, definitely the HbA1c will drop. But in terms of the duration of how long it will take to drop, actually, this is where actually back to our the trial, it shows that the earlier actually the legacy effect within a year. So you would like to have it a good control actually as early as within a year actually, because of to avoid further complication. I think that's all, Prof. Laila, for my presentation.
Right. Thank you very much, Prof. Shikin. I think Prof. Shikin has given us the overview about diabetes in very short 9 minutes or so. So now I pass the baton to Dr. Ken. Dr. Ken would tell us about the need of renal biopsy in diabetes, maybe for the next 8 minutes or so, quickly before I actually wrap up and end the CPC. Dr. Ken. Dr. Ken, you are on mute. You muted yourself.
Sorry.
Right. And
I
can
would
you
want
do
to,
your slide presentation?
Oh, haven't yet.
Yeah.
Yeah, can you see my slide? Yeah.
Yes, yes. Thank you.
Yeah, so sorry, I wouldn't want to take so much of a time due to the time constraint. So I just want to focus on 2 issues. When should we perform kidney biopsy in a patient with an underlying history of a diabetes mellitus? And then I'll walk you through the burden of a diabetic kidney disease in Malaysia as well. So all of us know that kidney biopsy doesn't come, it comes with a risk of a complication. So there is actually a systemic review look into the literature published from 1983 and 2018. Around 118,000 kidney biopsy was done. So 11% of them complicated hematoma and 1.6% complicated bleeding and need transfusion. And 0.6% of them actually complicated with death in the hospital. So bear that in mind, we shouldn't offer kidney biopsy simply to anyone with diabetes mellitus. But if only these patients came to you with a new onset of proteinuria, let's say they usually is 2 grams, they sudden onset from 2 grams become 11 grams, it's a new onset of high proteinuria, or let's say they have persistent microscopic hematuria, and you send a urine phase contrast showing a dysmorphic red blood cells, or you have an unexplained deterioration of a kidney function. Fast progressor is defined as a eGFR drop more than 5 milliliter per mils per 1.73 square. Or you have a relatively well-controlled diabetes mellitus and you screen for the target organ damage and which is none, then probably you can offer a biopsy. to look for the other causes. So what are the literature we have? What are the evidence we have? Can we rely on a diabetic retinopathy as a single indicator to guide us for biopsy or not? So I think for type 1 diabetes mellitus have a very close association between the diabetic retinopathy and diabetic nephropathy. It's around 95%. But for type 2 diabetes, the literature, the evidence is actually mixed. From a TUAN et al., it say that diabetes nephropathy has a sensitivity up to 87% and 93% of a specificity in predicting the presence of diabetic nephropathy. But however, another literature showing that diabetic retinopathy is only present in diabetic nephropathy around 60 to 65%. Its absence, it does not generate a negative predictive value. And another study showing that around 50% of the patients have a diabetes nephropathy. Actually, they do not have diabetic retinopathy. And at the same time, up to 40% of the patients with a diabetic retinopathy, when you biopsy them, they actually have other renal diseases. So diabetic retinopathy, it shouldn't be used as a sole indicator when it comes to a biopsy. You still have to go through the history and do a thorough investigation. So can we rely on a timeline of diabetes mellitus? So as in this case, this lady was diagnosed 3 years ago, but we all know that mellitus, it takes 20 years for you to get a kidney complication, up to 8 years for you to develop proteinuria. But as we say, this is only applicable to type 1 diabetes mellitus because we are able to pick them up early in the early onset of diabetes. But type 2 diabetes mellitus, they usually diagnose late and they come to us in the late onset of the disease. So we shouldn't rely on timeline also. And as you revise the case, this lady, the HbA1c was well controlled during our follow-up. But as what Prof. mentioned just now, there is actually a legacy effect. So from this slide, it shows that even though you have a very good control at the beginning for the first 20 years, but for the later on, the 10 years later, the protective effect of the microvascular complication is still there, even you're not on any medications. So again, we shouldn't rely on a few HbA1c reading and to conclude that patient is actually well controlled. So this map is just showing you the global burden of the diabetes mellitus. I think Malaysia is here. So this color is actually a deep blue color. Is here. It's more than 12%. So I think we have a high burden load of diabetes mellitus in Malaysia. And if you look through the tables here, from 2008 until 2018, the number of new dialysis patients is actually doubled. And if you don't like to look at numbers, you can look at the bar charts here. The number of dialysis patients is actually increasing in a tremendous trend. And the most of the contributing causes is actually in the blue line, which represent the diabetes mellitus as well. So it's definitely one of the main killer of the kidney. And from a US RDS 2018, showing the data here, Malaysia is actually on top of the country, having a diabetes mellitus causing the end-stage renal failure. So today we are a champion for nothing good. So the title for today is Eat That Frog. Why we choose frog? Because frog is actually the biggest and the most important and the most dreadful task. It is also a task that you will likely to procrastinate and neglect. So just like, for example, diabetes mellitus. So when you come to someone, diabetes mellitus is very common. Around 20% of the population with age 1 and 18 years old is actually having diabetes mellitus. So when you see them, we should actually treat them aggressively and early to avoid the complication. Because these are the tasks, very likely you will just neglect, then you neglect the diabetes mellitus, and in the end, patient might end up with complication. I think this is my last slide, and thank you for attention.
All right. Thank you very much, Dr. Ken, for the interesting sort of sum up. Yes, I totally agree with Dr. Ken. Eat that frog from the sake of medical student. Where's the frog? Maybe someone been asking, each other, where's the frog? Whether maybe they thought that you're going to present some nasty looking skin problem looking like a frog. So eat that frog meaning, the very most important is to control diabetes and hypertension, to retard or to stop the complication of both diabetes and hypertension, namely in this case is kidney disease, because once they have kidney disease and it deteriorates further, the patient will have to go for dialysis, increased burden for the family members and also the economy of our country. So with that, I would like to thank to all presenters, Dr. Lim Kuan Yee, Dr. Ken, Prof. Dashima, Prof. Shikin, and all the audience for tuning into our CPC this morning. Thank you very much.
Thank you. Okay, thank you. Thank you.
Okey, saya akan sharekan untuk Kahoot. Kahoot ni untuk medical student. So, gunakan nombor metrik, okey?
Lupa nak cakap Kahoot Buhari.
Tak apa, Prof.
I hope they listen and they able to answer. And to see how many actually been listening.
Kita ada partisipan tadi, waktu ramai tadi 200 lebih.
Yes.
Dan kita ada 50 lagi dekat FB.
Okay. The medical student dah tengah jawab.
Medical student dalam 100 lebih. Sekejap, saya akan share untuk Kahoot screen.
Okay. Okay. hadiah ke Cikgu Ari?
Ada hadiah Prof. Untuk makluman tahun 2020 telah ada pemenang
Okey.
dah ada pemenang dia, tapi keputusan dia tak ada dengan saya sekarang. Kami akan hubungi pemenang liga untuk tahun 2020 dan juga attendee yang paling kerap lah ni untuk medical student maknanya ada 2 pemenang untuk 2020. Okey. Terima kasih semua.
Okey, good. Terima kasih. Assalamualaikum.
Assalamualaikum.